Greetings, interprofessional collaborative team members. It is my pleasure to be here with you today. I am Dr. Irene Kane from the University of Pittsburgh School of Nursing. I am a veteran psych nurse with probably too many years of experience to count, so I'll keep that one a secret. We are here today to speak to, before I do start, I do not have any conflict of interest with the material that I will be presenting to you today. And we are here to talk about screening, brief intervention, and referral to treatment. A brief review for you. I know that you've seen this slide before. What is SBIRT? SBIRT is an evidence-based, comprehensive, integrated approach to the delivery for early intervention for individuals certainly who do have substance abuse disorders, and very importantly, I'd like to emphasize for those individuals who are at risk for developing a substance use disorder. And we are focusing on early intervention so we can intervene before serious consequences can occur. This approach is for all members of our collaborative team, whether we are in primary care, mental health care, inpatient hospital, dental, community. And I would like to emphasize that with just a very brief scenario. In teaching at one of our hospitals, we had physicians, nurses, social workers. We even had housekeepers join our in-service program. And as we were sitting in the emergency room setting, the housekeeper came out, this housekeeper who attended one of our sessions, and this individual told us about her interchange with the patient in the emergency room based upon the knowledge that she learned from the in-service program. And at that time, she suggested to us, and the physician who was sitting there, who was actually working this patient, that she thought this individual may have a history of alcohol abuse. The physician did not at that point screen for this individual, went back in and screened, came out, and I quote, profusely thanking this housekeeper and saying to her, "My goodness, you just gave me second thought on $1 million workup." Now, he may have been exaggerating. However, it's important to emphasize that this is a process that all of us can do, the entire team. And why SBIRT? You can be sitting there saying, okay, here's another task for me, but why SBIRT? Take a minute to examine the stats, all right? The 10 leading risk factors, causes of disability, adjusted life years. No. Tobacco is on that list in all categories, and alcohol. If we look at the high income countries, United States, that's us, tobacco's first on the list, and alcohol is 9. So we have made the top 10. I don't know necessarily that's where we want to be on the a top 10 list, but we are. So when we look at that, let's just take a second look at that 9th category of alcohol. What you have before you is a drinking pyramid. Okay? On this drinking pyramid, if we look at the bottom half of the pyramid, it's in green on your screen, you'll notice that it says low risk or abstinence and 70%. 70% is the percentage of those individuals who, when we interview and are doing our health assessments, who will actually not have any drinking issues, and they won't have, they may even be abstaining. One of the things to remember with that 70% though in our population is that you'll see to the side on the pyramid it says positive reinforcement. As health professionals, it behooves us to actually say something and comment to those individuals related to that behavior and how they are able to use alcohol appropriately. We should not forget that. Let's go to the top of that pyramid, or the 5%. Those are the individuals who are alcohol dependent, and we can readily, probably with a little bit of experience, pick out those individuals. In the middle, we have 25%, the number where we have those individuals who are at risk for harmful drinking behaviors. Earlier on, when we were looking at SBIRT, I was mentioning that we certainly want to look at this relative to early intervention. Here in that middle column is, we'd like to place a heavy emphasis on speaking to those individuals and screening to prevent, for the universal prevention, primary prevention, for those individuals at risk. Let's just take 1 second to look at the numbers. If we have 313 million people in the United States from the 2012 estimate, and we multiply these out, it's easy to see these in terms of percentage. 70% of that number is not at risk and they're abstaining, but 25% of those individuals who are at risk, that's 78 million people nationwide. So, professionals that we went over earlier, whoever we are, what do we think about? The professionals, we're like the professionals on this slide. What are we thinking about these numbers and how we fit on the top 10 list? And what does SBIRT have to do with this process and the numbers? And how can we use SBIRT? If we think of the numbers, we certainly have an opportunity, but even more so as a health professional with you. I'm part of this team. Maybe I'm in a different location, but we're part of the team. How can we help individuals in that 78 million category, all right, with SBIRT? All right, let's define first at-risk drinking. Okay, at-risk drinking for men, what we're talking about is, and that's that 25% group, all right? It can be the 5% group as well if they've been abstaining and are back into the drinking cycle. But men who have more than 14 drinks per week or consuming more than 4 drinks on a given day, women and those in the category of 65 or over who have more than 7 drinks per week or more than 3 drinks per day, or the third category, drinking more than 2 standard drinks per day without abstaining for at least 2 days a week. Okay? Now, what's important, that these are risks for exacerbating healthcare problems and healthcare issues, and why we may be seeing people in our respective healthcare sites. All right? Also important to clarify, these low-risk limits, when we're talking about these drinks, we're talking about and defining what we mean by a drink or a standard drink for ourselves and for those people who are before us, so that we are on the same page with what a standard drink is. So what is a standard drink? All right, a standard drink, as you can see on your slide, is a 12-ounce beer. It is not the Hofbrauhaus Stein. All right, it is a 5-ounce glass of wine, not that huge water goblet that we may see with some college students, or a 1.5 ounce of liquor. All right. I want to emphasize also at this point, when we looked at that 5% in alcohol dependent versus high risk, that alcohol dependence is not, I repeat, not defined as using alcohol every day, but rather alcohol dependency requires being diagnosed via a full assessment. And let me give you just a quick example to drive that one home. Just a couple of weeks ago, I was speaking with a gentleman who was in the doctor's office. The doctor just spoke with him regarding his elevated liver function tests. Okay? This individual was drinking 2 glasses of, I think he mentioned a Long Island iced tea. It's one of his drinks. I forget the other one. However, he was drinking 2 drinks a day for an indeterminate amount of time because he very firmly believed that would clean his arteries and he would not realize the cardiac condition that ran in his family. All right. However, the doctors mentioned that about the liver function tests, and this is a gentleman who then just cut out his drinking. He was not alcohol dependent, but yet he met the drinking standard. So it's very important that we are careful as we are making our assessments. All right, what can we do to help? First, we need to identify what's use, what's misuse, problematic use, and we can screen. We'll get to screens in a little bit. Importantly, connecting use or misuse to health-related issues, just like that physician did with the liver function test and the gentleman who was drinking thinking he was preserving his health. And he may have been, but the liver function test may have changed things for him. When we know there is a drink-related health or substance use-related health issue, we need to encourage consumption reduction. And we do that by conducting a brief intervention or refer for a formal assessment. Okay. On the screen, we have that pyramid we saw earlier. We just have to turn our head sideways and we'll catch it. All right, so basically we're looking at abstinence through dependence, and the percentages that we reviewed earlier. We have an opportunity to scan and screen with SBIRT to determine where that individual is before us for the health-related issue that they came to see us about, if there's any connection. Primary prevention, for those who are in that 70% category, that's the individual we want to reinforce, positively reinforce, and comment how well they are handling. For the 5%, we may need to move them back into a referral for treatment. For those who are at the 25% risk, we will be speaking about the brief intervention. The SBIRT model begins with that focus on risk because this is where, when I mentioned earlier and emphasized evidence base, 74% of high-risk individuals reported lowering their substance alcohol usage after 1 or more brief interventions. Think about that gentleman who was just told about his liver function test, just stopped. 48% stopped using it. And there are many testimonies. There are many YouTube videos where individuals are taking up the flag, if you will, for promoting that, in fact, they can respond to a brief intervention. SBIRT targets individuals who might be relatively symptom-free of a diagnosable substance use disorder, but who could be at risk for negative consequences due to their consumption patterns. We must keep this in mind as we look at the statistics and the ability to gain this kind of response to help the people that we see. Continuing, more evidence. Harris County, Texas, hospital district study. Patients reporting any days of heavy drinking, any days, dropped from 70% at intake to 37% at 6 months. Patients reporting any days of drug use dropped from 82% at intake to 33% at follow-up. So let's drive this home. We went over 313 million people in the United States. All right, 25% of those who may be at risk, that's 78 million people. If we did even 5%, if we even, if we took at 25% of 13, that's 78 million people who could be positively affected. Even if we did 5% of those people, it doesn't sound like much when we speak in percentages, but when we put the numbers of the population in front of us, it makes a big difference. And this is what we're seeing when we see this evidence base. SBIRT works. You can tell I'm a fan. SBIRT alcohol screening and counseling is one of the highest ranking preventive services among the 25 effective services evaluated using standardized methods. Take a minute to digest that sentence. It is in the top 25. SBIRT has been proven. However, it is also, for current levels of delivery, we are in the lowest of comparably ranked services, indicating that indeed we need to give SBIRT in our clinical settings and care delivery systems some special attention. And it's why all of us are joining you. Examples. In a study of 241 trauma surgeons, 71% did not screen. In a study of 7,371 primary care patients, only 29% of those patients reported having an alcohol screen. Right? Kind of emphasizing that 25, we're in the top 25, but we're not getting enough attention. So, what does that mean in terms of what is the screen? Let's read along this particular screen, point by point. First, screening is simply a preliminary assessment that indicates that a probability of a specific condition is present. So we're screening for a substance abuse use condition. Screening provides an opportunity for education, early intervention. It alerts the provider to risks for interactions with other medications or other aspects of treatment. Think about the gentleman with altered liver function tests if he wasn't screened for those 2 drinks a day, and other medication had to be utilized by that physician. It offers an opportunity to engage the patient further and has proved beneficial in reducing high-risk activities for people who are not dependent. We just looked at all of those statistics. Screening, summarily, is a process that identifies people at risk for the disease or disorder. As such, screening refers to a brief procedure used to determine the probability of the presence of an alcohol substance use problem. It substantiates that we have a reason for concern, and it identifies for us a need for further evaluation. So, you're a professional sitting out there. I'm a professional. I have community practice. Okay. What do we think? Let's look at some of the things that we do think. Oops. Well, I don't know about you, but sometimes I stand there and pull out my hair. You want me to do what again? You want another thing added to my list of tasks that I have to do? In less than 5 minutes, we could save ourselves an immense amount of time using SBIRT with our patients. I'm here to drive that message home. I've done it in 3. Discomfort with initiating discussions. We were at a local hospital teaching. It was a very close-knit community. The individuals who we were training with did not want to do an alcohol screen because they knew everybody. So we want to think about the process for how we do the screen. It can be, again, there are many options. If we make it a routine and everybody's doing it, it doesn't become an issue or a less issue. If it's part of the materials, we all have our clipboards we get when we go to receive our healthcare services. Screens can also be done by the patients. It's just as part of a routine. So the discomfort that we experience, there are answers to it. I spoke to the discomfort related to if something would happen or a condition became more complicated, the person became more ill, somebody was harmed because we didn't. I think that we would all recognize those as more difficult situations to have to partake in. And the other issue that came up was lack of awareness about screening. Indeed, we are all always learning new things. And we can, of all the three barriers, that we do have the tools for screening, are one of the easiest ones because there's innumerable tools out there. There is, and you have in your educational materials, a validated instrument called the audit, 10 questions. You also have the drug abuse screening test. It's a 10 question. These can be part of a clipboard to review very quickly when a patient is visiting the office or we're in the hospital, we're interviewing with the patient, whatever our sites. Right? There are tools that make our task quite easy. There are even shorter tools that give us enough information to screen from NIAAA, the National Institute of Alcoholism and Alcohol Abuse. There's a one question. The National Institute of Drug Abuse has a one question. The audit, the CAGE, the DAST, all of these, a variety of them. Whichever one meets our time needs, our barrier, any of those barrier needs, we can rapidly use to make a screen assessment to influence those stats. And what are the professionals saying? Well, there's Ms. Smith again, all right, going over. Now that she has the audit tool for that patient who's getting ready for discharge, it makes it easier. All right, we have a tool to rely on to do directly. Same thing with Ms. Kelly in her review of how many times, a quick question, in the past year you've had a drink. It's right there on the tool. And it becomes a routine process where the barriers can just be relaxed because people get used to it. Once we have a screen, we can move into the brief intervention. We're going to do that in a little bit more detail in our motivational interviewing module. But at this point, for the early and brief intervention, for those not ready to change, we are all Johnny Appleseeds. We are planting apple seeds all the time in our healthcare educational methods. They may not be ready to change, but a seed is there, and that individual will be thinking about what that professional said to them, because healthcare professionals are listened to. For those ready to change from that screen, that we've noticed there needs to be harm reduction, we have the opportunity to provide some advice on goals and to provide support for that individual to make the change. Again, just like that individual who had liver function changes. Importantly, the method we're going to choose, and that's why we have a separate module, is a method that cannot include moralizing with the person, finger wagging, shaming, anything on the list you see before you on the slide. The techniques that we will be using, motivational interviewing techniques, are those techniques that we will be able to incur those statistical advantages in our own population of patients to have a very good outcome from a very brief intervention. All it took for that liver function, the issue with the liver functions is saying, I notice that your liver function tests are elevated, and making the connection between the screen of 2 drinks a day. That's all it took. For a reduction or cessation of use, that's what we're looking for. Even starting to think about reducing, that's a start. To have harm reduction, and if indicated, working toward accepting a referral. We may find that, and we do tell people, that sometimes we can't do it alone, and that's okay, that we do have an opportunity for referral. And in fact, you will be having in your package with your cards a current listing of centers for substance abuse treatment, and those will be available. And this is part of our intercollaborative practice team. We work with all of these individuals to make a difference. We are suggesting that you make effort for a relationship with them so that you can have a handoff, a warm handoff, can speak knowledgeably about the individual that this patient before you may be going to, or there's also the 12-step program, and importantly, there's a learning opportunity here for some of the motivational interviewing techniques that will work to help that patient take the next step towards change. We will have a full module on what those steps are for practice and for learning. And I thank you for your attention and enjoy the next module.